Okay, well, thank you and welcome everybody to this week's Miami Global Brain Tumor Symposium. This is a weekly event that we do focused on brain tumor education and talking about the latest data, research, and technology in brain tumor treatment. My name is Michael Ivan. I'm one of the directors of the symposium, also an assistant professor here at the University of Miami and director of research of our brain tumor initiative. I specialize in brain tumor and skull-base pathologies. I'm joined today by my colleagues, Jacques Morcos, who's professor and co-chairman of our department, also the director of cerebrovascular and skull-base, Ricardo Comatar, professor and program director of our residency program and director of our brain tumor initiative and surgical neuro-oncology, and our newest recruit, Carolina Benjamin, who's assistant professor, director of our skull-base anatomy lab, and a skull-base and brain tumor specialist. Each week, we put on these symposiums, and I couldn't do it without all of the assistance from University of Miami and Sylvester Comprehensive Cancer Center and the team, including Christina, Ingrid, Ignacio, and Roberto. Thank you so much to everything that you guys do behind the scenes. If anybody has more questions about tonight's symposium or future symposiums, please, you could find us on our website or on social media. We're on Twitter, YouTube, and Instagram. All of these sessions are recorded and then posted on YouTube, so you could watch them at a later date. And please reach out to us if you have any questions. On Thursdays, we have a very similar symposium run by Dr. Morcos, which I'm a co-panel. And tomorrow, we have a cerebrovascular skull-base symposium featuring Dr. Froelich and Dr. Evans talking about chordomas, endoscopic approaches. So really with sticking with endoscopic pathology this week, it goes well together. Also, a quick preview and teaser for next week on our symposium. We'll be welcoming John Lee from the University of Pennsylvania talking about intraoperative molecular brain tumor imaging using near-infrared fluorophore. So please be sure to tune in next Wednesday at the same time. Quick housekeeping for participants, please. We try to make this as interactive as possible. Use the Q&A button at the bottom or the chat. We'll try to get to all the questions throughout tonight's session. We don't offer CME, but you will get an email confirmation documenting participation. And please be sure to like, follow, and share our videos and upcoming symposiums on social media so we can keep growing and sharing all the great knowledge that the experts, including Dr. Augie, get to share with us. So this week, we have a great panelist from across the country, starting with Dr. Zwagerman, who's assistant professor of neurosurgery from Medical College of Wisconsin. He's director of pituitary and skull-base surgery at the Neurosciences Center. We'll also have Dr. Forbes joining us, assistant professor of Department of Neurosurgery at the University of Cincinnati, brain tumor skull-base expert. Dr. Karji, who's associate professor in clinical medicine and endocrinology and our specialist in neuroendocrinology here at the University of Miami. He also directs our endocrine fellowship. And Dr. Zachariah, who is associate professor, co-director of neuro-oncology and director of the brain tumor and skull-base surgery program at Penn State University. Thank you to all the panelists for joining us tonight, and they have some great cases prepared for everybody. Our special guest tonight is really, I'm very excited to introduce. He's been a close friend and mentor of mine now for many, many years. I was very lucky to train underneath him at the University of California, San Francisco, and that's Manish Aghi. He's a professor of neurosurgery at UCSF, and he's a part of their Center for Pituitary Disorders and vice chair of the department. He's a principal investigator at the UCSF Brain Tumor Research Center, as well as his own lab, the Aghi Lab, which has some amazing research. You can see in the Aghi newsletter, which comes out yearly. You can find that online. He's also director of their Center for Minimally Invasive Skull-Base Surgery. He's a past WNS and CNS tumor section chair and a part of the editorial board. And the list of accomplishments just go on and on and on. He focuses on gliomas, awake surgery, as well as pituitary and minimally invasive endoscopic approaches for brain tumors, and has been publishing on that now for over a decade with some amazing research. He also has a brain tumor lab, as I noted, with NIH funding ever since 2008, which is just a tremendous accomplishment, something we all kind of look up to and try to seek after the true physician scientist. So Dr. Aghi, thank you so much today for joining us all the way from the West Coast and sharing us with some of your experiences with Cushing's disorders.
Thank you, Mike. Really appreciate the kind introduction. So, as Mike alluded to, I'm going to be talking to you today about giving you sort of a primer on Cushing's disease for neurosurgeons. This will be a sort of evidence-based, literature-based review, talk about some of our experiences at San Francisco. But I'm also going to try to make sure we leave plenty of time, not just for questions, but for case presentations, because so much of this is nuanced and really personalized decision making that may vary from center to center. But really quickly, by way of overview, I'll talk briefly about some of the symptoms of hypercortisolemia or Cushing syndrome in general, because there is certainly some interesting biochemistry there. Talk more generally about causes of Cushing syndrome, because one of the important questions as the provider that we face is, is it a central source? And in thinking about that, it's always important to keep in mind what else could be the cause. So with that in mind, then transitioning into diagnosing Cushing's disease, although I am a surgeon, the surgical portion of my talk will be somewhat brief and actually more about decision making than about sort of fancy anatomy or videos, because I think Cushing's disease is really the ultimate sort of make you think type disease for a surgeon, which is really wonderful. Talk about diagnosing and confirming remission or cure, what to do when you fail to get remission, which happens to all of us as much as 20% of the time, and then how to manage recurrence, which also happens to all of us as much as 20% of the time. And then if you do get durable remission, just being aware of some of the long-term considerations in these patients that may come up in your conversation. So without further ado, symptoms of Cushing syndrome, we've all sort of seen this in medical school and throughout our careers, but it's really a condition that affects virtually every organ system in the body. The two most common systemic manifestations are hypertension and diabetes mellitus. And in fact, those are among the areas of focus in some of the medical clinical trials for Cushing's, as well, and some of the classic sort of physical appearances, the hump on the back, the thinning of the limbs, the striae, and the central fat deposition, as well as the easy bruising, are very classic when we see them. And the mechanisms of all these things are certainly interesting. There's impaired wound healing and sort of these skin changes, which are due to cortisol's immunosuppressive effects on interleukins. Cortisol also is a natriuretic hormone, so it induces sodium retention and volume expansion, causing the elevated blood pressure, reduces the end organ sensitivity or responsiveness to insulin, and that's the cause of the diabetes. Suppresses GnR release at the hypothalamus, so that causes the amenorrhea. And direct effects stimulating adipocyte growth, but in a central manner, it causes the obesity pattern. And this enhancement of bone reabsorption at the level of osteoclasts and blasts really makes those patients prone to fractures. And in addition, they don't get enough calcium because of the effects of cortisol on calcium absorption in the gut, as well as calcium secretion in the urine. There's a lot of work on mood disturbance in patients who are hypercortisolemic, and extensive studies have shown alterations in neuronal networks in patients with Cushing's disease. So this is functional MRI data just published this year, in which you see that the neuronal networks really throughout the brain, but particularly those in the amygdala and hippocampus that control mood regulation or felt to control mood regulation, are considerably diminished in patients with Cushing's disease, in a manner that is only partially reversible with biochemical remission, as I'll talk about later. I wanted to talk briefly about special patient populations, and two that come up are pregnant women and pediatric patients. So pregnant women with Cushing's disease are, of course, rare because their amenorrhea may make it difficult for women with Cushing's to get pregnant. But when they do, Cushing's disease can actually occur in a variety of ways. It may be a new diagnosis, or it may be recurrence of previous patients who are in remission, just because the very nature of things that grow in a dysregulated manner during pregnancy. It's a difficult diagnosis to make during pregnancy because many of the things that happen in Cushing's are also common during pregnancy. But some of the things that distinguish Cushing's from pregnancy are the pattern of striae, with this sort of coloration that is going to be white during pure pregnancy, but more of a bruising appearance during Cushing's. And also hirsutism and acne will distinguish Cushing's from pregnancy. Typically, you want to manage their symptoms, but you want to wait until after delivery to treat the hypercortisolemia. And there are certainly major risks to the fetus as well. In pediatric patients, interestingly, the pre-teenage years, most of the time you want to think about adrenal tumors, but in older children, the central source will be more common. There's a lot of literature about pseudotumor cerebri or intracranial hypertension after you achieve biochemical remission in Cushing's. And it turns out this is rare, but when it does happen, it happens in pediatric patients. So, worthwhile connecting them for ophthalmologic exam after remission. And there's certainly effects on adult height even after you achieve biochemical remission. So how do we think about Cushing's syndrome before drilling down on Cushing's disease? And the important thing is that certainly 2/3 of the cases of Cushing's syndrome are going to have a central source, but many won't, and many of us will have incidental adenomas on MRIs. So you want to really think this through before jumping into an MRI and making that link. And so you certainly want to rule out iatrogenic causes or exogenous steroids, and just be thorough there. And also think about adrenal tumors in cases where there's just a bit of a mismatch between what you're seeing radiographically and what you're seeing clinically. And of course, there's biochemical tests if you have uncertainty about a central source. And so Cushing's disease, of course, will arise from pituitary adenomas, typically microadenomas, more common in women than men. And these are patients who have ACTH oversecretion, which will not only affect production of cortisol, but other steroids as well. And in the original series, tragically, Cushing's original series, these patients would die within 5 years. But since the advent of transsphenoidal surgery, as well as other adjuvant treatments, the 5-year survival is now 99%. Although, as I will talk to you about later, it's still not perfect. And it's, we have to continue to strive to get better in this area. And so moving on to how we diagnose Cushing's disease. Well, of course, we want to start by diagnosing Cushing's syndrome. And so when you've got a clinical suspicion, the formal endocrine society guidelines suggest that you have at least 2 of 3 positive tests. And these are, in no particular order, the 24-hour urinary free cortisol, the midnight or late night salivary cortisol, and then the third one is the low-dose dexamethasone suppression test. So the idea here is that the 24-hour urine will capture and overcome the sort of variation that occurs throughout the day. Another way of occurring the variation that occurs throughout the day is to get that late night salivary cortisol, because if you get the test in the middle of the day, it'll spike even in ordinary people during their day without Cushing's. But in the presence of, in the absence of Cushing's, we should all go down late at night, but Cushing's patients do not, and that's where the saliva comes in. Although typically most endocrinologists will have a patient do 3 salivas in addition to 1 other test. And so then the low-dose dexamethasone suppression test is a nice test. Our endocrinologists actually include that as one of their 2, particularly because many patients who have Cushing's disease, paradoxically, the very manifestation of their Cushing's disease may cause them underlying stress. So I had a patient I literally operated on last week where I was convinced she had Cushing's, and my endocrinologist said, you're probably right, but she actually had a hip fracture as a manifestation and was scheduled for hip replacement 4 weeks after the transsphenoidal. And they made me get the low-dose dex suppression because they said this patient is in incredible pain from her hip. And that can elevate her cortisol even at night with the saliva and even in the 24-hour urine, because both were sort of borderline elevated. And so the low-dose dex suppression sort of, because you're measuring a circuit, sort of reduces that effect. And so it can be done in one of 2 ways. The easier way is and what we did with my particular patient was give 1 milligram of dex around 11 p.m. and then have them go to the lab at 8 a.m. for a blood cortisol. And the alternative, which is a bit more cumbersome, is 2 milligrams spaced out over 6 hours for 48 hours. and then you check 3 consecutive days of urine. But this obviously, that's much more cumbersome. So typically you'll do the overnight. And if it doesn't drop, then Cushing syndrome is certainly suspected. So having gone through that process, I will say I did touch on it, but if you can't get to 2 of 3 positive tests, you want, at least on the endocrine side of the endocrinologist, to keep persisting if you have strong clinical evidence for hypercortisolemia. But these tests are certainly an important part of the diagnostic workup before you go to surgery or whatever treatment you're considering. A rarely used test would be the DEX-CRH test, which is sort of designed to rule out this pseudo-Cushing syndrome where you have asymptomatically high cortisols due to underlying depression, anxiety, alcoholism. And those patients you give, along with the DEX-CRH, to stimulate pituitary ACTH release. And the DEX should prevent that effect in pseudo-Cushing's patients, but not in Cushing syndrome. So now, how do we know that we have a central source biochemically? Well, rarely used, but you can do a CRH stimulation test or the high-dose DEX suppression test, which will distinguish a pituitary adenoma from an ectopic source. Part of the reason it's rarely used is that, if you have an adenoma and a match with hypercortisolemia, the data would support, moving forward with the presumption of a central source. But and then if you have a negative MRI, as I will talk about in a moment, there are other tools available before you need to go to the biochemical test for a central source, but these certainly do get used from time to time. So what do we do if the lab suggests a central source? And so now you get an MRI to look for the adenoma. Because of the fact that these are small tumors in patients with Cushing's, of course, a conventional 1.5 Tesla, and I call that conventional because that still is the field strength in many MRI machines, will only detect 90% of adenomas. So it's certainly good, but what do you do with the remaining 10% of cases? So I'm going to go through a couple of options here, and the first is jack up the field strength. So many of us now have access to 3 Tesla MRI, which will show lesions. Here's an example of an officially read negative 1.5 T MRI, but a lesion on the left in a patient who got a 3T MRI. So that's certainly step 1. Even better resolution if you have access to a 7T MRI. Gabby Zada's group at USC looked at this last year in JNS and found they were able to detect hypoenhancement in 9 out of 10 patients with negative 3 Tesla MRIs. 7 of those went on to have corticotrophic adenomas in the same spot. So in general, if you find something in an imaging modality, the odds are in your favor that it will be a corticotrophic adenoma. But be aware that if you jack up the strength, your false positivity rate does go up a little bit. So you just want to exercise caution. But luckily, the specificity is still pretty good with higher strength. The other option that we use and have published on is dynamic MRI. So focus on the pituitary and acquire images at multiple time points after gadolinium administration. And so we and others have shown that this will detect adenomas in 96% of these patients who have non-diagnostic conventional field strength MRIs with a 16% false positive rate. That's not much higher than the 10% rate of incidentalomas that we have in the general population. So that certainly, in fact, in our practice sort of comes before really IPSS or anything, and we certainly don't do a lot of 7T. We have that as an option, but it's more for research. And other groups have looked at FLAIR, and specifically not just FLAIR on a routine scan, but there is this phenomenon that a microadenoma might wash out contrast in a way that is detectable by a post-contrast FLAIR brightness. And so one could consider putting on your requisition to get FLAIR sequences post-contrast in patients with Cushing's, and the group that looked at this reported a positive predictive value of 92%, but sensitivity not great at 55%. And the last one that I have used once, shown in this example here, but relatively rare, would be PET. And for PET of the pituitary, you can't use conventional FDG tracers due to the high background in the brain. but you can consider 11C-methionine, which is only taken up by the pituitary and has some enhanced uptake by most adenoma types. You can also use a somatostatin receptor agonist to localize somatostatin receptor positive tumors, which certainly include patients with Cushing's. Their adenomas should light up, but these are very tricky modalities, and lateralization can be tough. But I did have one case illustrated here, in a patient who had prior surgery, had essentially a partially empty cella. And that's the other thing, is a lot of these negative MRIs arise from patients who have partially empty cellas, either from prior surgeries or just a native partially empty cella. And so now you're struggling to find hypoenhancement in a very thin thing. And this particular patient, we had somatostatin ligand with PET that localized adenoma to the right inferior cella. And I was able to obtain biochemical remission with the PET guiding the surgery. And this patient had prior surgery, so IPSS wasn't an option, but the PET in this case was useful. So I think the important thing is just to be aware of all the tools at your disposal when you manage these patients. Which brings me to IPSS. So IPSS, you're going to catheterize the right and left petrosal sinus before and after CRH stimulation, measure ACTH, and normalize to what's seen in a forearm vein. Higher ACTH in a sinus compared to the forearm vein will indicate a central source. And this is an important point, that we all focus on IPSS, or at least I did when I started my practice, as a tool for lateralization. And in doing so, you underappreciate how good a tool it is for centralization, to confirm central source. And so if you have a negative MRI and you pursue IPSS, I mean, technically at that point in time, unless you've done the biochemical test for central source, the IPSS, you're doing it for looking at lateralization, but in reality, you're doing it for centralization before even thinking about lateralization. And along those lines, the test as a lateralization tool will lose its reliability in the setting of prior surgery, as the venous drainage will reroute and no longer lateralize. But basically, if your pituitary to peripheral ratio is greater than 2 or greater than 3, in the setting of CRH administration, you've confirmed the central source with essentially 100% sensitivity and specificity. With the ratio between 1 to 1.5 or sort of less than 3, then you're looking at ectopic Cushing's. The lateralization cutoffs in the literature are 1.4 or 0.7, depending on what the numerator and denominator are. And it's accurate in predicting localization in about 2/3 of cases. I've just shown here an example of a patient from my practice who had a right to left ratio well above 1.4, consistent with a right-sided tumor. And this brings up another point, which I will get to later, which is that although these ratio cutoffs are appropriate for exploration on one, or a biased exploration on one side or the other, if you're considering something more aggressive like hemihypophysectomy, our preference is to use a stricter cutoff of 3 before considering something like that, where there's a little more morbidity, and I'll get to that in a moment as well. So finally, as a surgeon, we do want to talk a little bit about surgery. If you have a known target you're going after, such as a microadenoma with clear imaging on MRI, Oldfield and others have demonstrated the importance of using the pseudo capsule of the compressed normal anterior lobe that surrounds the adenoma as a useful guide and sort of dissecting tool to preserve the integrity of the surrounding adenoma. And so you're going to cut through that initial layer to get down to the pseudo capsule. And once you're in the correct plane, any dissector or ring curette can be applied in that plane, and it should not cause the adenoma to lose its structural integrity. And at that point, you want to go around circumferentially and with a microadenoma, essentially deliver it on block. And if you do that, there's no study that I'm aware of that sort of does randomization or anything, but certainly Oldfield series, obviously, is sort of the godfather of the surgery, quotes a very high rate of biochemical remission, higher than other studies in the literature, with the caveat that by definition, if you have a pseudocapsule, you don't have the cases, you have a positive finding, so you don't have the cases of a negative MRI included in a series like that. And those are the cases that water down most people's published remission rates. But regardless of that caveat, it's certainly an important technique to keep in mind. But what do you do if the MRI is negative? And intraoperatively, ultrasound is a valuable tool as part of an exploration with 73% sensitivity and 84% positive predictive value in cases with a negative MRI. John Lee, who I was thrilled to hear is speaking, I believe, next week in this series, does a ton of work in near infrared dyes, so I will not steal his thunder, other than to just hint at the fact that he does great work with folate analogs, which folate receptor is expressed by most adenomas. But the caveat, as far as I'm aware, is that most of his studies to date, and he may correct me on this when he speaks next week, but have included, at least the published ones, patients with radiographic adenomas. And so the question is, how good a tool is this in a patient with a negative MRI? And I know John is actively working on a dye that would have specificity for a corticotrophic adenoma, which is really the holy grail of this field, because if that's the case, it would not even light up an incidentaloma and would really give you surgical confidence. But in the absence of those technologies, the standard that we all do with a negative MRI is transphenoidal exploration, and everybody has their different preferences. Mine is paramedian, superior, inferior cuts on both sides, biased towards a side of lateralization if I have good IPSS data. And more than half the time that will release, some tissue with color and suspicion for a microadenoma. And ideally, if you can get into that early, you can maybe even still find a pseudocapsule and get the sort of ideal surgical outcome that you start out looking for. So the other nuances of surgery to think about perioperatively, I don't certainly give these patients preoperative steroids, but postoperatively, obviously, they all need to be on replacement. Our endocrinologist practice is dexamethasone and until they've proven to subnormalize with an AM cortisol, and then they transition to hydrocortisone in that situation. Many of these patients will have obstructive sleep apnea, so the usual precautions around positive pressure ventilation and even airway for your anesthesiologist, and then blood sugars and blood pressures, precautions intraoperatively as well as postoperatively. And then, as I mentioned with my patient from last week, pathologic fracture, so tremendous care during positioning. Our patient with her hip fracture was intubated on her stretcher, and then extensive lifting help and padding were utilized. So how do we detect post-op remission? And this is one of the real challenges in the field. You do a great surgery and you want immediate feedback. How did I do? And so this is actually a graph I put together of all the series that I could find with sufficient sample size in over 2 decades, published remission and recurrence rates. And interestingly, I remember looking at this years ago, and what you notice is that sort of lower, that there was a sort of correlation between remission and recurrence rates, which if you dive down into it, it's sort of this idea that more stringent criteria will lower your remission rate, but also lower your recurrence rate. And it almost suggests that there are some cases that are borderline remissions that pass an easy test and then just end up recurring later in time. But the criteria can certainly vary between undetectable versus subnormal postoperative serum cortisol. My patient last week had undetectable the morning after, and that's certainly wonderful, but subnormal is also a very good place to be. Some people will actually do a low-dose dex suppression post-op. Our practice is not to do that. And some people rely on the 24-hour urine. We only do that if there's some uncertainty or ambiguity. But essentially, we rely on serum cortisol the morning after surgery, and that's certainly the practice of most people, but I've just put these other things to consider as well. And this is from a published this year meta-analysis of 68 studies, in which they did this forest plot and essentially, quote, an 80% overall remission rate at the time of first surgery, which is very much consistent with a pretty tight 95% confidence interval. Recognizing that this includes everybody, includes people with macroadenomas invading the cavernous sinus and people with negative MRIs, which brings me to the next topic, which is, what are some factors that predict your likelihood of remission? And reduced likelihood, not surprisingly, in every series associated with macroadenomas or the other extreme patients with normal MRIs, cavernous sinus invasion as well. Despite the advances in the field, including medial cavernous sinus wall resection, et cetera, still a challenge to obtain biochemical remission in that setting. The things in your favor would be microadenomas, experience of the surgeon, and an immediate post-op cortisol that's undetectable or subnormal. And here you can see the weighted impact of those risk factors. Cavernous sinus invasion really causes it to plummet. Micro versus macro, not as bad as you would think, but certainly a statistically significant difference as well. And negative MRIs versus positive MRIs prior to surgery, also not as big a difference as you would think. And then first surgery is your best shot, because at revision surgery, as I get to, it drops from 80% to around 60% remission rate. There is this concept that several people have talked about of delayed remission, and it becomes an important topic because of this issue of, should I take my patient back to surgery with if I didn't get normalization of their cortisol the morning after surgery. The best series that I'm aware of, or one of the earlier ones, came out of the Mass General, where they had a 71% immediate control rate. But then they also had this small but significant subset of patients, around 6%, with delayed decrease in their cortisol, on average 38 days after surgery. Mechanisms of delayed remission that have been theorized, one is adrenal hyperplasia with some adrenal escape just in the setting of chronic elevated ACTH. But the argument against that is that these patients with delayed remission have also delayed drop in their ACTHs. So it seems like whatever's occurring is not adrenal escape, but it's more at the level of the cell or the pituitary. Others have theorized about late necrosis of residual tumor cells after surgical manipulation. And that's indirectly supported by the fact that patients who have late remission have increasing evidence of negative pathology. So maybe you left the adenoma behind, but the patient was fortunate that you sort of caused some event that slowly infarcted their tumor over time. And then Danny Providello has talked about delayed remission as, if you don't get a pseudocapsular dissection, those patients are more prone to delayed remission. But that's different than what the MGH group talked about. Those are more delayed on the order of 1 to 2 weeks. The Mass General group is talking about delayed more in the order of a month or a month and a half. And my experience is that those patients are rare. The delayed ones that Danny talks about, which is sort of, biochemical remission at 1 week, that actually you do see on the order of 10%. And at Danny's postulated hypothesis is certainly possible there. And so the other thing about the Mass General report of note is that their delayed remission patients had a 43% recurrence rate compared to 14%. So this goes along with what I was talking about with the diagnostic criteria. If you, let some patients into this club, so to speak, of remission, and they barely meet the standard or they meet it in a delayed manner, the durability of their cure may not be in your favor at all. And so I, again, haven't had many of these in my practice, or really any, but if I were to see them, I would be certainly very cautious in watching them after surgery. So what are your surgical options if you have no remission after the first go around? So if you had an MRI that suggested you were in the right spot and there's a tumor, repeat surgery, certainly. And historically, everyone talks about immediate surgery, and that has been our practice as well. Those cases are rare, where generally, if there is an MRI finding, you should be able to get remission on the first go round. But we also don't jump right in, with the sort of the next morning, but we give it an extra day or two, because a few more people will jump into remission. Some have argued about waiting even longer for delayed remission, 30 to 45 days. That's not our practice, but I've seen people do that. And so I put that out there as a question for discussion or a thought. But if the MRI is negative and you didn't obtain remission because you basically had a negative exploration, in that setting, if the IPSS was strictly lateralizing, at that point, we would certainly consider hemihypophysectomy. And the questions that come up there are, do you do that at the time of first surgery? I mean, you know by your eyes you have a negative exploration. Do you just do a hemi if there was strict lateralization at that time? I leave that as an open question because I have colleagues who do it both ways, and I myself give them time after a negative exploration. And then if you give them time, do you do the immediate re-exploration or wait for delayed remission? I'm more sort of in the early category there. And hemihypophysectomy has a remission rate that's, varies a lot depending on the series. Ours is sort of hovering around the low 60%, but a fairly favorable rate of new hormonal deficits. And I wanted to throw out a study from Kevin Lillehei, Colorado, where he does this sort of 2/3 resection. So he makes a right cut and a left cut for his exploration. And then if the exploration is negative, he connects them via a horizontal cut that essentially allows 2/3 removal, the sort of lateral extremes and then the inferior portion of the gland. And with a cohort of around 24 patients published 2 years ago, he quoted a 82% remission rate and the still sort of favorable rate of new hormonal deficits. So something I thought was a nice study to just throw out there as another consideration as well. This is data from my time in training, actually a while back at Mass General, but thought that was interesting, this idea of immediate reoperation. And immediate reoperation certainly boosted the biochemical remission rate, both in patients with microadenomas or even those who had a normal MRI, but was not considered in patients who had macroadenomas because presumably there was some invasive component that was inaccessible the first time. And so definitely an argument for immediate reoperation there. This is the remission rates I mentioned earlier after vision surgery from that same meta-analysis. So now it drops from 80% to 60%. And interestingly, if you look at repeat surgery, the indications for the repeat surgery affect your remission rate. If it's recurrence, like true biochemical recurrence, you've got sort of a similar 80% remission rate as you had at the time of the first surgery. But if it's due to a failure of the first surgery to work and you're taking them right back, now it drops to 54%. And so that's an important consideration when you go back to repeat surgery in the setting of failed biochemical remission, is that the individual case level, it is sort of close to a flip of a coin, still a strong consideration, but something to think about. If you are fortunate enough to fulfill your goals of biochemical remission, you want to obviously be aware that these patients will be hypoadrenal for up to the first year. And I had some interesting experiences early in my practice with this, which is, we had this face sheet that we gave all of our transsphenoidal patients, and we had a practice of putting them all on steroid replacement, which is our endocrinologist practice. Not everyone does it that way, I realize. And so we would tell them to hold their steroid replacement for testing at a 6-week post-op appointment. And one of those instruction sheets went out accidentally, unfortunately, to a Cushing's patient who was in the exam room when I went to see him, pale, literally about to pass out, and had to be rushed to the ED in hypoadrenal crisis. So be very careful in your practice with how you treat your Cushing's patients compared to the rest of your pituitary patients, as their needs are exquisitely unique. And I'm going to sort of not spend too much time on sort of replacement other than, because it's all out there in the literature as well. But I will say no data favors the use of one glucocorticoid over another. But our endocrinologists favor hydrocortisone because of inefficient activation of the DEX to provide the true sort of cortisol replacement effect. But then they don't start it until we've proven remission because we don't want it to contaminate the blood results. And also hydrocortisone is preferred by our endocrinologists because the ability to space things out and adjust temporally to suit the patient's needs throughout the day. And so how do we manage, what do we do if we fail to attain remission after a first or second surgery? Well, the first thing is just pause and gather your thoughts. Did you really have a central source? And so one thing you can rely on is this, the specimen you take out, even if it didn't have the adenoma in it. Was there evidence of hypercortisolemia, such as Crooks-Hyland change? because in the situations of glucocorticoid excess, you should see that histologically, and that sort of is a helpful confirmatory tool that you've got pathologic hypercortisolemia. I'm not going to go spend too much time on medical management. I will just say a variety of mechanisms and areas in the pathway for cortisol biosynthesis that can be targeted. And there's really two agents with FDA approval. One is mifepristone, based on the seismic study, and particularly useful in patients with hyperglycemia. And so that's the FDA approval. It was for hyperglycemia associated with surgically refractory Cushing's disease. And then the other FDA approved agent was pasriatide, which is a somatostatin analog. And it's FDA approved, but FDA also acknowledged that surgery was the primary treatment, with pasriatide useful in patients who fail to achieve remission after surgery. And so hypophysectomy, relatively rare due to the endocrine morbidities, but the remission rate is certainly good, but the pituitary insufficiency obviously goes along with that. And so I will say relatively rare. Bilateral adrenalectomy, on the other hand, we have seen more of because the laparoscopic techniques have made it acceptably safe compared to historically what it was prior to laparoscopy. And the quality of life in patients with the advent of laparoscopy has been very good. And of course, we want to be wary of Nelson syndrome in patients who undergo adrenalectomy. So what do we do when these recur? And unfortunately, that is a sad reality. Even in the most expert hands, as many as 20% of patients will remit, typically within the first 3 years, although everyone in practice long enough will see a case of remission as long as 20 years out from the original surgery. I inherited a Charlie Wilson recurrence 20 years out from surgery when I first started my practice. And so these are a sad reality of the disease. It's aggressive biology. And so transsphenoidal surgery for recurrence, although not as effective as first-line surgery the first time, is still the recommended first approach. And here you can see the published series that I put together for transsphenoidal surgery for recurrence. And the box sort of shows you where most of the studies for first surgery go. And only 2 out of 9 series managed to get their remission rates in the setting of recurrence comparable to first surgery, but the other 9 out of 11 were well below that. The failure to achieve remission after multiple transsphenoidals or in the setting of recurrence that fails to obtain remission can be managed with radiosurgery if there's a suspected target due to cavernous sinus invasion or even strict lateralization. Of course, it takes time to achieve remission. Here are the published rates of remission with radiosurgery for Cushing's disease, and you can see they fall well below the rates with first surgery, but are comparable to the rates with second surgery. ACTH secreting adenomas in general are more responsive to radiation than other types of hormone secreting adenomas, so that's certainly good. When I trained at Mass General, we had proton beam rather than photon methods, and certainly this offers very much more focused dosimetry and theoretically a high remission rate, but also a higher rate of endocrine dysfunction. So these are some of the considerations that we face, and because many of us as surgeons will manage the radiosurgery for these patients, and so we want to be cognizant of those issues as well. Suppressive medications can reduce the efficacy of radiation, so will typically be held. This is more a consideration for some of the other hormone secreting tumors, but certainly your Cushing's patients, by the time they come to radiosurgery, may be on medications that you want to consider holding prior to radiosurgery. Hypopituitarism, obviously very common with radiosurgery for Cushing's patients, and we try to keep this low by managing our dose not to the normal gland per se, but to the stalk, and keeping it below 6 gray in that situation. Lastly, I wanted to touch on some of the long-term considerations after you obtain remission. I think this is an under-thought of area, but there are examples of increased morbidity and mortality and sort of chronic impairment of quality of life in patients with Cushing's disease after remission. Here you see rates of stroke, thromboembolic events, and sepsis, obviously very high around the time that they're diagnosed with Cushing's disease. And you have data from patients well before they're diagnosed with Cushing's disease. And so it's almost like these patients have an acceleration of their events that eventually leads to the diagnosis of Cushing's disease. But interestingly, if one is the standardized normal sort of control population, even more than 3 years after remission, their rates of stroke certainly dropped to, sepsis certainly dropped to normal, but stroke and thromboembolic events, they remain at risk for those. And there's also studies, including from our group, that show age-adjusted mortality in patients with Cushing's disease after remission is lower than not just healthy controls, but patients with non-functional adenomas who undergo surgery or acromegaly who undergo surgery. There is some sort of hint of an effect that some sort of previous transient exposure to hypercortisolemia has an effect on your mortality that is not just, it doesn't go away after remission. I mean, it gets better, obviously, but it's also in direct proportion to the duration of your hypercortisolemia, underscoring the importance of getting these patients into remission in a timely manner, which is not necessarily a surgical issue since we operate quickly, but an important issue for medical doctors who see these patients to make their diagnoses in a timely fashion. And even quality of life impairment can persist in some of these patients. I mentioned earlier neuronal circuitry being rewired in the setting of Cushing's disease or Cushing's syndrome even. Cortisol elevation reduces the volume of hippocampus. This has been shown not just in Cushing's, but in aging and PTSD. And the effects are due to reduced glucose uptake in hippocampal cells that are bathed in high cortisol, which causes atrophy of human hippocampal neurons. And it's only partially reversible during remission. And so these are some of the things to think about in terms of the effects that these patients have to endure. And, we as surgeons play a very significant role in getting them back on track. But Cushing's is really a biochemically complicated disease, and one that I'm glad we're all engaged in the kind of discussions such as today. And so just a couple of bullet points to wrap up with before we go to cases and discussions. Cushing's disease is caused by ACTH secreting adenomas, and identification will often require advanced imaging modalities. Remission, achieving it in a timely fashion is important to prevent patients from suffering the long-term effects of hypercortisolemia. And remission is typically best started with transsphenoidal surgery, although certainly radiosurgery and medication or even adrenalectomy can be considered in patients who have failed to achieve remission. So with that, I'd like to thank you for your time and really excited for further discussion.
Thank you, Dr. Augie. That was a great review for residents and neurosurgeons alike. A couple questions we have here is, one was from Bruno, wants to know, in the COVID era now, how are you doing anything different with these patients as far as the acuity of when you treat them, how you're approaching your surgery, and what your protocol is?
Yeah, so the first, I would say, 2-ish weeks of the crisis, maybe even 4 weeks, when we did not have sort of universal testing, we did surgeries with N95 masks and aerosol prevention around the surgical site with a special draping mechanism. We've reduced those things because we have standardized testing for all the patients who come in. I think the other thing the question may have been getting at is, is there sort of a delay option? And I would say that, my adenoma patients, if they have maybe a small macroadenoma without vision loss, and they're just doing this for long-term sort of protection, maybe in the beginning, those patients were putting off surgery, but Cushing's is sort of, in some ways not far behind macroadenoma with vision loss in terms of its level of urgency. So we get those patients in even with COVID.
Okay, great. Well, I want to get to some of the cases. Dr. Forbes, I know you have surgery going on later on, so if you want to go first.
Yeah, well, thank you, Mike. Are my slides showing up okay there?
Not yet.
Not yet.
Okay. Okay, how about now? Is that, you seen that or?
No.
Let me try this. Here we go. Okay, it's telling me screen sharing has failed to start.
You should be able to share.
There we go. Okay. So this is just a very quick case. That was a fantastic discussion, by the way. And this case is more a kind of a polling of what all of the panelists do in terms of laboratory monitoring after surgery. So this is a 26-year-old female presented with weight gain. 24-hour urinary free cortisol, midnight salivary cortisol were noted to be elevated. She had a low-dose dexamethasone suppression test and did not suppress. She did suppress on the high-dose dexamethasone suppression test. And dynamic MRI, which I'll show in the following slide, demonstrated a suspected 2-millimeter lesion on the involving the left sella. IPSS was consistent with a central origin and localized to the left. Here is her dynamic MRI. And so you can see the adenoma localized to the left side on dynamic MRI. And so we made the decision to take her to surgery. And here is just very brief operative video. And so an adenoma was encountered. And in general, we prefer extracapsular resection when possible. And so this was a very straightforward case. And so the tumor was removed. And so post-operatively, in terms of her laboratory values, so her post-operative cortisol at 2:30 p.m. was noted to be 24.4 micrograms per deciliter. At approximately 8 p.m., this had dropped to 4.8 micrograms per deciliter. 3 hours later, she had reported some nausea, had a single episode of vomiting, and was given 100 milligrams of hydrocortisone. 30 minutes later, the blood draw was 2 mics per deciliter, and then her cortisol level post-op day 1 was 14.1 micrograms per deciliter. So in general, with a focus on post-operative laboratory analysis in Cushing's patients, in agreement with what Dr. Aghi had said before, in the early post-operative period, the decision must be made whether, number one, remission has likely been achieved. Number two, whether return to the OR for additional resection is indicated. And it's interesting in more historical series, you find that it was fairly common actually to return to the operating room, and I think we're to some extent moving away from that. And so a lower threshold for return to the operating room is going to result in a higher incidence of postoperative hypopituitarism. In some studies, the incidence of postoperative hypopituitarism after a return to the OR has been quoted as high as 41%. So the question is, if we're monitoring laboratory studies after transfenoidal resection for Cushing's disease, do we follow the cortisol nadir? Do we focus on the post-op day 1 or post-op day 2 8 a.m. cortisol? And the answer is that it depends according to who you ask. There's a good study by Ironside et al. That demonstrated with a nadir cortisol less than 5 micrograms per deciliter, they had a long-term recurrence rate of 9%. When that nadir cortisol dropped less than 2 micrograms per deciliter, the recurrence rate dropped to 6%. And some studies have called for an abandonment of the practice of early repeat surgery based on early postoperative cortisol levels in all patients, but those who remain profoundly hypercortisolemic. And a study about 10 years ago by Shugro et al., I believe in their study, they looked, they designated subnormal levels as an 8 a.m. cortisol level less than 8 micrograms per deciliter, and they had a 4% rate of recurrence when this was achieved. In this study, patients with supernormal levels were excluded, but normal levels, postoperative cortisol rate of recurrence of 22%. And from this, the conclusion that normal postoperative cortisol levels don't necessarily rule out a durable hormonal cure. So with all of this information in mind, I kind of wanted to poll the group to ask them what protocols or laboratory criteria, if any, do you use when considering early return to the OR following initial surgical treatment of Cushing's disease?
Nathan and Brad, you want to go first before we hear from Dr.
Yeah.
Agi?
Sure. Yeah, Jonathan. I mean, that's a great case. Mine will be actually very similar in the question being similar, which is this kind of what's your trigger to go back to the operating room? And I think I've kind of begun to follow a little bit of I think kind of what you've outlined in your kind of literature review and your protocol here, which is I tried to do what I think is an aggressive initial operation, exploring the gland bilaterally, in addition to removing the microadenoma if identified, and then a period of observation if I do see it is subnormal AM cortisol, even if it's not undetectable or extraordinarily low, and before making a decision for early operation. But
yeah, and very similar to what you talked about already. We are a little bit more aggressive here. We monitor cortisols every 2 hours for the first 24 hours to kind of track the changes that happen. Oftentimes after 24 hours, if I don't see the cortisols heading below 10, certainly that I would consider getting an MRI and taking them back pretty quickly. If I get a cortisol level below 5, oftentimes what we'll do is we'll treat them with steroids because that's sub normal levels, and then follow them long term. But taking them back is one of those things that depends on what you find in the OR, if you think you actually got it, or if you find that you weren't really successful in finding what you saw there. So I don't have a strict criteria, but at the same time, if the cortisols aren't heading the right direction, I get an MRI quickly just to make sure I didn't see anything obvious. And then if they don't go below 5, I'll take them back.
Yeah, just a comment. I think the last 3 Cushing's patients that I've operated on were operated elsewhere, and you could kind of see the writing on the wall, and they all kind of had this kind of normal level cortisol afterwards, where they were hopeful that they would go into remission. And then, by the time they saw me weeks to months later, they had already kind of recurred. And then the question is now you don't know exactly the extent of resection that was done before, other than the MRI, and how do you approach that? And I agree with everybody else. Trying to be aggressive early on is definitely the best approach. Dr. Agi, anything you want to add?
Yeah, no, I think I agree with everyone. I mean, the Chagru study was some of our institution, and so the supernormal patients are the ones we get most where we consider it, going back. The other thing that comes into play is the original time of surgery. Like, you really don't want to leave any doubt. So, if there's something you're hesitant on, like really don't be in a position where you're sitting there the next day and you're like, oh, I could go back and do X, Y, and Z. Like, if there was something that could be done, do it the first time. And then, but the supernormal ones are the one, it would be supernormal and then something about the operation where you're like, I could have done something better. And so if that combination is pretty rare, but it may happen from time to time.
Yeah, I think those are great thoughts, and I would agree with what everyone said. I think ideally we like to see that level, the nadir, drop to below 5, and we routinely, when we see it drop below 2, that's when we automatically replace glucocorticoids. But I would agree absolutely with what you said. So thank you, and unfortunately I have to take off just a little bit early. We have unfortunately have our virtual symposium for interested medical student applicants here. So, but thank you.
Thanks, Jonathan.
yeah, thanks, Jim.
Thank you.
Nathan, you want to go next?
Sure, happy to.
You can go ahead and share over top.
You guys see my slides okay?
Yeah, looks good.
Good. Again, once again, thanks for inviting me. And my cases that really emphasize some of the points that we brought up earlier during Dr. Agi's talk. So I appreciate that. And you'll see what I'm talking about in a second. First of all, I have no disclosures. very similar to the patients presented, at a 25-year-old woman who had the typical features of Cushing's, elevated accelerated cortisol levels. She had an abnormal DEX suppression test because she didn't have an adequate DEX level. But we do a DDAVP stim test here, and it was consistent with Cushing's disease. Her imaging was shown here. Oh, it's not quite showing. But it looked like to be there a 3 millimeter nodule on the right side of the pituitary gland. We took her to surgery, and so you guys have all seen this before, typical kind of approach for this. I do fairly wide exposure, opening the dural lobe to avoid potential CSF leaks that you guys have all seen before. But what you'll see here is, as I get in here, you start to notice that there's a little nodule there that looks abnormal. It doesn't really look like a tumor to me. It looks much more like a Rathke's cleft cyst, kind of that proteinaceous fluid. But I wasn't sure, but that's close to where the lesion was. So we took more of it. And again, looks much more like a Rathke's cleft cyst to me, but that was what the lesion was. So we ended up resecting that and getting the whole thing out and opening the cavity. Don't see any residual of that proteinaceous fluid there. And we did our typical closure for her. Post-operatively, her cortisols and ACTHs didn't crash at all. She remained elevated. We didn't know what to do. We waited for PATH. PATH usually takes 3-4 days for it to come back. And when the PATH did come back, it came back as Rathke's cleft cyst with ACTH staining cells. So what do you make of that? She went home off of steroids. Eventually, we did further workup. We got IPSS, again, to confirm that we had a pituitary source of her Cushing's disease. It lateralized to the left, even though we did surgery before. And we took her back to the surgery for the resection. Again, you can see some of the scarring that's been there before. A different dural opening this time because I want to make sure I get a really good view of the entire gland. And as you'll see during this case, we started doing a section and we started noticing that there's more whiteness over here on the edge. And more concerning for tumor, obviously, as we did further dissection into the area, made the vertical cuts that you guys have talked about. Eventually, you'll see that we actually found the tumor. There it is, the bright whiteness that you see. And we're able to separate that around the capsule and then resect it in its entirety in the pseudocapsule that we've been described. So this is, again, much more consistent with tumor. Post-operatively, she did quite well. She crashed pretty quickly down to really, really low levels. We discharged her on steroids, and she remained cured of her disease at this point with normal pituitary function. But I think this case emphasizes what you have talked about already. First of all, it's always okay to stop and regroup if things don't look the way that you expect them to look, especially in situations where people can have multiple lesions or incidentalloma. Trusting the data, again, I could have taken her back right away, but I just wasn't quite sure what the results were going to be and what we had taken out. Obviously, patients can have multiple lesions, and my initial gut instinct was that this didn't look like tumor, like we've seen before, but certainly something that we should keep looking for, and obviously be persistent and be aggressive, especially if you're not sure you accomplished what you want to do. And as has been brought up earlier, an MRI may be unreliable and unhelpful. Increased and better imaging modalities are going to be beneficial for us in the future, but at the same time, the MRIs don't necessarily show everything. So.
Great case. Thanks, Nathan. My question is what is your threshold for IPSS in these cases? I mean, obviously in this case, you felt like there was an obvious lesion in the gland, but when you went back and you did it, it looks like it localized to the left, which is where you found the tumor. So yeah. I wonder what the panel's kind of threshold for doing that. If you see an image on MRI, if it's an obvious lesion, but what if it's a subtle lesion? What if there's no lesion? What's kind of the threshold for pulling that trigger?
Yeah, so I'm fortunate from my perspective. I have a really good group of endocrinologists. If I see a lesion there and I'm fairly convinced that it looks real, it's not small, it's not like a smudge, but it looks like a definable lesion. Before this case, I would have used the DDAVP stim test and a confirmed pituitary source. I would assume that's the case. I think after this case, when it comes to using IPSS, certainly it was helpful, and helpful to lateralize in this case, but that's not always the case. But most of my patients with microadenomas will end up going either a DDAVP stim test or get a Petrosal sinus sampling.
Dr. Karji, any thoughts on the DDAV stim test versus the dexamethasone suppression?
Right, yeah, so the DDAVP stim test is typically used to distinguish pseudo Cushing states from true Cushing's disease. And so it's similar to CRH. And when CRH is unavailable, we oftentimes use DDAVP. Some of you may have actually gone through periods of time where CRH wasn't available. And even during Petrosal sinus sampling, DDAVP was used. It's not quite as potent a stimulator of ACTH, but it's a good second best to CRH.
Okay. Dr. Augie, any other additional thoughts?
Yeah, no, I think those are good cases. And also we do see, if you go back far enough in our series, even a handful of collision pathologies, and RAFK is a common, the entity is rare, but if you were to see two pathologies, RAFK or two microadenomas, you'll see it. And especially with true collision pathologies, there's probably something about the imaging that from one entity that obscures your ability to see the second. So there's been examples of people who go back to surgery, just like that case, which was great, or as well as people on whom an MRI a few weeks after they've recovered will show a more clear target. So those are very important things. And just, considering exploring the gland, particularly when you've got discordant results between an IPSS and an MRI, being very cognizant to take out the lesion that you see on the MRI, but look for other lesions as well.
Okay, Dr. Karji?
We're good. All right, I hope you can see my slides.
Yeah, looks good, thanks.
Okay, well, thank you all for inviting me, and it's nice to be an endocrinologist among neurosurgeons. I think after listening to that masterful talk, we need to invite more neurosurgeons to talk to us. We usually do at least have one at Endocrine Society, but also invite Dr. Aghi as well. And there's a well-known joke about what happens when endocrinologists talk about Cushing's disease to neurosurgeons, and it ends with the neurosurgeon sacrificing himself by jumping out of a lifeboat, exclaiming, "Not another talk by an endocrinologist about Cushing's disease." So my case has some similarities with some of the previous cases and some differences. So this was a patient referred directly to our endocrine clinic and had been seen by an outside endocrinologist in the community, a 48-year-old woman who I believe during the evaluation for primary biliary cirrhosis had imaging of her abdomen. And she was referred initially for assessment of bilateral adrenal nodules. So you can see in 2014 and 2015, she was found to have bilateral adrenal nodules. And quite interestingly, the record review showed that the outside endocrinologist appreciated that the 24-hour urine cortisol was dramatically elevated. So 346 micrograms, that's about 7 times the upper limit of normal. And you can again see why the urine cortisol is so much more helpful than a blood cortisol, because an AM cortisol of 14.6 overlaps with what you can see in normals. Now, what's interesting here is she underwent 2 adrenal vein sampling procedures. I guess they were trying to differentiate which of these 2 adrenal nodules was causing her Cushing's. And these, basically were not really helpful. And as we looked through the evaluation, we realized that we didn't see any ACTH levels documented on the patient. So this is going to be really important as we discuss about what was done next. I'll go through these quickly, a little background. She had some clinical features, but not overwhelming of Cushing's listed there, and some comorbidities at a fairly young age, such as osteopenia and insulin-requiring diabetes. A really important point in all of these patients that are referred for Cushing's disease is to review for causes of possible pseudo-Cushing states. So sleep apnea, pregnancy, alcoholism is a really big one that we can miss, and several other conditions. I can recall just this summer, having 2 patients referred to our neurosurgeons who were emaciated, basically cachectic, and someone checked their cortisol in the morning, which is reasonable to rule out adrenal insufficiency, the other end of the spectrum, which could cause weight loss. But when they found that was high, they failed to recognize, and these are endocrinologists, that this is just normal physiology, that the purpose of cortisol is really to increase during starvation to mobilize valuable energy stores, and they were referred to our neurosurgeons. And so, it's important to understand cortisol can increase due to causes other than tumoral pathologic hypercortisolism of Cushing's disease. And on physical exam, again, she had some clinical features, but not very overwhelming of Cushing's disease. And so we continued the workup, realizing that no ACTH levels had been documented. Could this be a pituitary Cushing's disease rather than an adrenal driven process? We continued the workup. A repeat urine cortisol was again markedly high, and we performed a 1 milligram overnight dexamethasone suppression test, and her cortisol failed to suppress normally. It went down to 7.8. However, the ACTH was not suppressed. So, it's common in patients with pituitary Cushing's disease, to have adrenal hyperplasia, including nodular adrenal hyperplasia. So this is, something coming from an endocrinologist that was referred to us. It's a little surprising. I don't think this patient needed adrenal vein sampling at all. 2 late-night salivaries were ordered, but were not reported by the lab as the specimens weren't collected correctly. And because she does have adrenal lesions, aldosterone, renin, and metanephrines were ordered and were all normal. And here's an image showing the bilateral adrenal adenomas so you can review. So our thought process at this point was that this is most likely a pituitary Cushing's based on the response to the dexamethasone suppression test and the non-suppressed ACTH levels. It certainly is ACTH-dependent Cushing's, which could be ectopic ACTH or pituitary. But one question I had before proceeding was, could it be possible, and maybe we can ask this to others if they've seen this, that a person could have an ACTH-secreting pituitary adenoma and the adrenal gland nodules gain autonomy? I think Dr. Aghi discussed this in part of his discussion. So even though you remove the pituitary tumor, if the adrenal nodules are autonomously producing cortisol independent of ACTH, the Cushing's would be improved, but not completely resolved by the surgery. So I thought, well, let's knock out the ACTH completely with a high-dose dexamethasone suppression test and see what happens to cortisol. And the high-dose dexamethasone suppression test is also helpful in distinguishing Cushing's disease from ectopic ACTH production. So after taking dexamethasone, it's really important. I recommend to everyone to also measure the dexamethasone level to make sure the patient took it and it wasn't cleared or not absorbed well, and it was adequately high, and her cortisol was 3.1. And so, different criteria are used for interpreting this to distinguish ectopic from pituitary Cushing's disease. Most people state that if the cortisol declines by more than 70%, that's more consistent with pituitary rather than ectopic. And others use a cutoff of 5, that if the cortisol after 8 milligram overnight dex suppression is under 5, that's more consistent with a pituitary. So we were satisfied at this point enough to obtain an MRI of the pituitary. And a 1.2 centimeter lesion here in the left side of the pituitary, really without significant cavernous sinus invasion, was noted. And sometimes we will throw in a CRH or DDAVP stimulation test, especially if the lesions are microadenomas prior to proceeding to surgery. And if the microadenomas are extremely tiny or non-existent, we'll do Petrosal sinus. But we felt comfortable discussing with our neurosurgeon, who was our very own Jacques Morcos, who saw the patient and took the patient to surgery. And so the patient underwent transfenoidal surgery. The lesion was seen and removed. However, our protocol is, since we discussed this as a group, is to operate without glucocorticoid coverage and to check post-op day 1 and day 2 AM cortisols. And we look for numbers under 2 ideally, but if the cortisol is under 5, we usually send them home with glucocorticoid replacement. And if it's above 5, we send them home without glucocorticoids. I can't think of any patients I've seen here in my over 12 years of working at University of Miami that we've taken immediately for reoperation. So we'll wait for a delayed remission at least a few weeks and reassess the patient before making that decision in my experience. So she was sent home without hydrocortisone replacement. And, and the question was, let's reassess her. There are delayed remissions, but with those numbers, I think that's quite unlikely. So a few weeks after surgery, she was seen, fortunately she hadn't developed DI or hypopit. The 24-hour urine cortisol, you can see the late night salivary cortisol, was even higher than before. And a useful test that I also employ is to check diurnals. So you can see an 8 a.m. and 4 p.m. cortisol. Normal physiology dictates that the cortisol should decrease quite a bit, more than 50% by the afternoon. And this sort of flatlining of cortisol is highly consistent with a tumoral production of either ACTH or cortisol. And so the question here was, did this patient not have a pituitary Cushing's case, or could there be a second tumor somewhere that we didn't see? Or could this patient who didn't look very Cushingoid have a pseudo-Cushing state that we weren't aware of? As I mentioned, sometimes alcoholics and things can be missed, but you saw her photo, I think, earlier on the exam slide. She's a devout Muslim, and we didn't really think that was the case. And the question was, what should we do next? And we decided to do it's clear that she has ACTH-dependent Cushing's, was to do our Petrosal sinus sampling. And you can see here, even at baseline, there's a strong central to peripheral ratio with some lateralization to the left. And then after the administration of CRH, the ACTH levels increase at all sites, again, consistent with a pituitary source in this particular case. And another MRI was done here a few months after the initial surgery. And we really didn't see very clear evidence. The report certainly was negative. I discussed with Dr. Morkos, and we thought that perhaps here, centrally located, there might be a more posterior small lesion that may have not been seen, or was, because of the larger tumor was somewhat masked on the initial MRIs. And so here's the op report from Dr. Morkos's May 2017 pituitary exploration, where he saw a small lesion, definitely creamy whitish material, centrally, posteriorly, slightly to the right of midline, which was sent for surgery. However, the pathology came out as no evidence of adenoma, and it was a pretty detailed note that was put on here, and stating there is a population of ACTH positive cells extending into the posterior pituitary. Obviously, we have the post-op cortisol before we have the path report, and the post-op cortisol levels were extremely encouraging. So they were both under 2 micrograms per deciliter, and she didn't develop any permanent pituitary dysfunction after the surgery. She was steroid dependent and was able to be weaned off of steroids at approximately 6 months, and her diabetes and hypertension have entirely resolved. So this is now about 3 years later. I still follow this patient in my clinic, and she still remains in remission from her Cushing's disease.
Yeah, great case. It brings up the question, when we see prolactinoma and we could see their size and we correlate the amount of prolactin, and we could correlate and say, oh no, like that's a huge prolactinoma and the prolactin's only 50, then it's probably not really a prolactinoma. Does that come into account for Cushing's? So I'm not sure, Dr. Avi, if you saw that 1.2 centimeter lesion and the patient didn't have Cushingnoid features, would you be suspicious, or would that be enough to kind of raise some red flags?
Yeah, my sense is that the correlation isn't quite as good as it is for prolactinomas, and I believe that others have reported that as well. So I think starting with the visible abnormality was certainly reasonable. And if I recall, even was this one where the IPSS matched where they found the small tumor or the big? Oh,
yeah. It matches more where they found the big tumor.
Yeah.
Rather than the small tumor, which may have been a little more centrally located, but the op report stated the small tumor was to the right of midline.
Yeah, that's what I thought.
Now, this IPSS is, again, done after surgery, and you had commented that sometimes that can change the venous drainage.
Right, yeah, this was after the first surgery. Yeah, no, definitely a very challenging case, but a great outcome nonetheless. Okay, any other comments, Brad?
No, a really interesting case.
Okay, let's go to the last case then. Thanks, Atil.
And I'll kind of go through this pretty quickly because I think we've touched on a lot of these points. Again, I think this is all about the decision making, and I think Amisha's talk was fantastic. Really covered so many bases of this complex disease, and I look at these as some of the more complex cases we do in a lot of ways. It's not a technically necessarily difficult operation, but the decision making, intraoperative, preoperative, getting to that point. And I think doing a thorough job in the operating room is so much more difficult with these tumors than it is with something like a non-functioning adenoma, and requires a really kind of meticulous attention to detail. So this is a 56-year-old woman, very similar presentation with non-specific symptoms of fatigue, some striae, proximal muscle weakness. biochemically fairly straightforward. She was non-suppressible with low dose dex suppression. Had late night salivary cortisols that were elevated. Her 24-hour urine cortisol was unremarkable. This was repeated. She had persistent elevation of AM cortisol and imaging that demonstrated what looked like a fairly obvious microadenoma, just eccentric to the left. And I'm going to take some liberties here because I don't have the actual operative video for this. So this is operative video for a different case, a case that was a little less definitive in terms of where there was an adenoma. Thought maybe something off to the right. She did have IPSS, which actually lateralized to the left, so kind of not really concordant with the imaging. And so this is really just to highlight some of these principles that I think Dr. Aggie had mentioned. A lot of this is from kind of the principles from Dr. Oldfield's kind of approach to these. And I think a meticulous approach really is critically important here. So you'll start with really wide exposure of not only just the dura, but wide exposure over the cavernous sinus, bilaterally, completely exposing the entire gland. He talks about kind of doing this subdural dissection so you could really see the inferior aspect of the gland. You can see the whole surface before you make a decision and you dive into it. This is putting some gel foam between the gland and the cavernous sinus to kind of rotate the gland out. Immediately do this bilaterally to see the lateral surface of the gland. And again, using the IPSS and the information you had before. So I thought I saw a little subtle abnormality, a little bulge where I thought correlated with the imaging, trying to do a pseudocapsular dissection, so sharply dividing the gland there. Ultimately, you'll see it kind of pop into an area where I see some soft adenoma come out there. And then I try to reestablish a plane, a pseudocapsular plane around that to identify and stay outside the capsule of the tumor. Again, just like I was mentioning before, you try to do a thorough job there, but I will still, again, and particularly in this case, because the IPSS is removing some of the dura there, I will explore the contralateral half of the gland, making sequential cuts vertically into the gland and exploring that, working back towards the posterior gland, and then just doing final inspection here. And so, well, that was a different operation. That's kind of the standard way I do these, and it was very similar. And then this young woman, again, her cortisol came down to 8 at its nadir. She was clinically demonstrating some signs of adrenal insufficiency, the standard kind of nausea, just not feeling well. So she was sent on hydrocortisone. The remainder of her function was intact, and pathology did reveal an ACTH corticotroph adenoma. And again, this gets back to that same question, which John Forbes had kind of alluded to, which is, what's our threshold to take somebody back like this if you feel like you've done a thorough operation? And the sense I gather from the group here is we're probably not jumping back into the operating room unless we feel like there was something maybe we could have done additionally in the OR, and we have maybe supranormal cortisol levels. And so this is one where we kind of hemmed and hawed. Certainly cortisol level not really where we wanted, but we decided to just watch. And so again, we talked about all the options here, and we ultimately waited. This was her post-operative MRI, which really shows no evidence of residual adenoma in that area. And she's at this point now, 3 years out, doing well with a 24-hour urine cortisol that's within the normal range. Continuing with endocrinologic follow-up, but really being told, we think she's somebody who's at potentially higher risk for recurrence, given that she didn't nadir early, and somebody who we're going to keep a close eye on.
Yeah, great case, Brad. It also highlights the point and how nice it was here that you were able to actually have a positive pathology, because as Dr. Karji had kind of found with Dr. Morkos that that the pathology was negative, because sometimes I've seen it happen both with me and in training that the tumor is so small, as you're trying to make the slices through the gland, you end up just the tumor comes out and goes up the suction so quickly that then you have a negative pathology, and then you have this questionable post-op Cushing cortisol level.
Yeah.
And then do you know if were you in it or were you not in it, and that's difficult.
Yeah, I did another one recently where it seemed fairly obvious at the time of surgery. Microadenoma, got a really nice resection. Same thing, explored the gland and sent a little bit for frozen just to be confirmed that it was actually adenoma. and final pathology was more consistent with like hypertrophy. She did drop dramatically in terms of her cortisol level, completely adrenally insufficient. And so I think it's one where it's nice to have that pathology confirm it, but maybe there was just a small adenoma contained in what you resected, or path went up the suction, but always leaves you wanting a little bit.
Yeah, Dr. Augie, your threshold for if you don't see something to do a hypophysectomy on the first go.
So I haven't been doing it on the first go, but I have colleagues who definitely do. And the reason I don't is I've had a few remissions where I thought the exploration was negative, but somehow they went into remission, and something about just the exploration, had something go up in the suction that I wasn't even aware of. And so it's the same reason that, I'm not necessarily rushing back to surgery, but most negative explorations are likely not going to perturb hypercortisolemia. So if you've got a strict lateralization, I think upfront hemihypophysectomy is certainly a consideration, but that hasn't been my practice.
And then
I think if I had a very strong lateralizing IPSS and I were there, a lot of times I would consider doing it. And I've gone doing more the lateral half of the gland. I know you had mentioned, and Oldfield talked about that as well, doing kind of the inferior quarter and the lateral quarters, and really kind of coming up with very similar remission rates. Honestly, with seemingly very similar remission rates to complete hypophysectomy. And so just obviously with a much higher endocrinologic morbidity. So I will oftentimes remove a portion of the gland at the time if the IPSS lateralizes strongly.
And one last question for Dr. Karji as well. So on recurrence, when you pull the trigger to do medical therapy or radiosurgery, is it based on your cortisol levels or clinical symptoms that the patient is experiencing? Is it better to treat early with some of these adjuvant therapies when you see the cortisol starting to rise before they become symptomatic? You have better outcome, or is it better just to prolong that until they really are symptomatic again?
I think that most of us, if the biochemistry is mild and the patient is fairly mildly symptomatic or asymptomatic, might continue to observe some of these patients. I'm not really aware of data on long-term outcomes, and the treatments are not without morbidity themselves, including the gamma knife. And we're all developed, and I know, Mike, that we have a clinical trial, and there's several clinical trials out there for patients with Cushing's syndrome. So I encourage all of you to encourage patients to consider these for medical therapies, because it's not, in the other functioning pituitary tumors such as prolactinomas or acromegaly, our medications, I think, are both, more effective and especially have a better side effect profile. And the holy grail is to find, really good medications. I know ketoconazole was mentioned by Dr. Aggie, and, that drug has a lot of issues, including liver toxicity and drug-drug interactions, among other things. So we use them, but we have to really balance the risk-benefit analysis in doing that.
Dr. Augie, any comments on your threshold for radiosurgery for recurrence? And
yeah, I think another consideration for sort of observing someone who might be mildly borderline for recurrence and letting the situation declare itself is most of your tools at your disposal, including radiation or medication, or even surgery, if you've got something more definitive, maybe more proliferative, it's going to be more responsive biochemically. And something like radiosurgery, you kind of only have one shot to get it right. So although it takes a while for radiosurgery to work, it also works better if there's a known target that you can plan around. So those are some of the considerations that come into play.
okay, great. Any lasting thoughts? Otherwise, we're kind of at the time. I want to thank everybody. I know everybody's kind of running off to their things, but Dr. Augie, Dr. Karji, and everybody else, thank you so much for your time. That was a phenomenal talk, and I think a lot of people will be learning a great deal from it.
Thanks, everyone.
Thank you. Have a good day.
Okay, good night.